Mhm.
Well, good evening, everyone, and welcome to tonight's presentation that we're calling Don't Ignore That Heart Murmur. We're pleased you've all come to join us at Franciscan Health for this webinar and for making your health a priority. I'm your host, Jenny Hawk, Senior Marketing Specialist for Franciscan Health. Our surgeon has some great information to share with you this evening. By the end of our time together, you will know more about what causes a murmur, a little more about heart valve disease in general, and what you should do when you've been told you have a heart murmur, including when to be prepared for surgery if needed. Now, before we get started, I'll just go over a few housekeeping items. For this virtual visit, participants are muted. We ask that you remain muted to help us avoid background noise and interruptions. If you have questions to ask our presenter, please type them in the chat window. We'll be answering your questions at the end of the webinar during our Q&A time. Our administrator, Kirsten Wachowski, is taking care of everything on the back end this evening. If you experience any technical issues, just type them into the chat window and we'll work to resolve them as quickly as possible. Now, if you miss anything, don't worry. We will be sending the recording of tonight's presentation to you in a follow-up email. All right, so let's get started. I have one question to ask our attendees. First, we'd like to know a little bit about who you are and maybe why you're here. Right now, we have more than 20 people listening so far, and I'm sure we'll have more checking in here shortly. For our first poll question, please choose the answer that best describes why you're interested in this topic tonight. 1, I've been told I have a heart murmur, but currently don't experience any issues or side effects. 2, I have a family member who has a heart murmur or has had heart valve surgery, and I want to know if this puts me at risk for valve disease. And 3, I'm interested in learning more about heart valve disease and current modes of treatment for this condition. Now, more than one may apply to you, we realize, but please choose just one for now. All right, we have more than half of you choosing number 1, that you've been told you have a heart murmur, but currently don't have any side effects or issues. And about 30% are interested in learning more about heart valve disease and current modes of treatment for the condition. All right, very good. Thanks for participating in that short poll. I'll introduce you to our presenter. He is a board-certified cardiothoracic and vascular surgeon with Cardiac Surgery Associates and is a member of our Franciscan medical staff. Dr. Michael Tuchek is a graduate of Midwestern University in Chicago, Illinois. He completed a residency and fellowship at Loyola University Medical Center in Maywood, Illinois. He has several clinical interests, including heart valve repair and replacement, transcatheter aortic valve implantation, and minimally invasive heart and vascular surgery. He currently teaches at his alma mater, so to speak, at Loyola University Medical Center. Franciscan has been able to take advantage of his teaching talents by having him record podcasts on heart disease topics, and you can find those on our website. Now, for a cautionary tale for this webinar, Dr. Tuchek has incorporated some video footage of actual heart valve surgeries he's conducted. He will alert us when they are coming up, and you will know when they are coming up, and in case you'd rather not watch them. Now, I'm not a medical person myself, and so I'm not used to seeing these kind of images, but the videos are really short and actually very interesting. So I will be watching. But if you'd rather not, just turn away briefly but stay with us for the rest of the program. So, Dr. Tuchek, welcome. And thank you for bringing this current topic to our attention. You can bring up your presentation, and Kirsten and I will turn the program over to you now.
Okay, can everyone hear me?
Yes.
Great. All right, well, thank you, Jennifer. That was a nice introduction. I don't deserve it, but I hope everyone can hear me online. I'm going to be talking about heart murmurs tonight and why you shouldn't ignore them. I'm going to try and make this fun. I hope I will let people know about the surgeries ahead of time, but if I don't, they're not that graphic, but hopefully you'll learn something about, minimally invasive, maximally invasive, and why we're all talking about murmurs so often these days. So let me begin if that's okay. So my agenda, what's a heart murmur? Heart valve anatomy. You can't go through school and high school biology without knowing anatomy. We'll talk about stenosis, which is narrowing of structures, insufficiency, regurgitation, leaking. Why is it bad? Some open surgery treatments, transcatheter treatments, minimally invasive treatments, and then we'll try to answer any questions you have. So
please pay attention. This message is for your own safety.
So that's just to try and point out that if you're not willing to watch surgeries, this may be a little more than you want, but hopefully not too bad. So I hope you can enjoy it. So who am I? Well, I'm a heart surgeon, as we just talked about. I also used to fly when I had hair, that is. I covered up as a French chef, but I'm not a very good cook. I actually do vacuum wearing a suit. I know it doesn't look so good. And with those knobby knees, you can tell I'm not a world-class surfer by any means. But what am I really? Well, I'm a professor of cardiothoracic and vascular surgery at Loyola University. I've been there about 35 years. I'm the director of the structural heart program there. I do a lot of investigator work, including the core valve PERC trial. Our group is at about 30 hospitals. We're the largest group in the country for cardiovascular and thoracic surgeon. And of course, I'm chief of surgery at Crown Point currently. And yes, I'm very proud to say I'm a region rat from Maryville High School. And to prove it, there I was on the golf team way back in the day. I only have one groupie there, so I'm not sure how popular golf was back in high school. So let's talk about anatomy. There are 4 heart valves: the tricuspid valve, the mitral valve, the pulmonary valve, and kind of the most important, the aortic valve. And the heart squeezes, and when that happens, some valves open and simultaneously some valves close. And that fancy graph is just saying that valves just do one thing. They keep the blood going one way. So when you have an aortic valve, in this case, the last valve out, it opens up all the way nicely on the top there, and it closes all the way nicely on the bottom. No leak, no stenosis, no problem. But when you have aortic valve stenosis, narrowing of the valve, it doesn't open up very well, nor does it close very well. So blood can't get out and the blood leaks backwards, and that's a bad combination. You can see what it looks like normally on the top, opens and closes nicely. On the bottom, it's hardly opening at all. Well, what does that sound like? I hope you can hear this, but this is a normal heart tone, the lub-dub that you always hear about. It gives you your blood pressure of 120/80 with each one. But when you have a stenosis, you hear that swooshing sound. I'll stop talking for a second so you can hear it. It's certainly not a lub-dub, open and close. There's something going through it, and that's the turbulent flow of blood going through the valve that's not working well, in this case, aortic stenosis. It's more moderate. It gets a little more high-pitched sometimes, so that, like putting your finger over a hose, the water squirts out at a much faster velocity, and that's what you're hearing is the velocity is going up as it's going across that narrowed valve. And when it gets really severe, which you can see here, the noise starts going down because there's almost no blood flow going through it, and it just can't generate noise anymore. And that's what murmurs are, basically. There's lots of reasons for them, but we're going to start with just the stenosis kind of valve problems. When you have severe valvular stenosis, it's bad for a lot of reasons. First of all, when you get symptoms, you may not have any. Some of you already said no symptoms, but when you do have symptoms, shortness of breath because the blood's going backwards, chest pain, can't get blood to the coronary arteries, syncope, in other words, passing out, no blood's going to your brain. You get tired, palpitations, irregular heart rhythm, edema, your legs swell up, or dizziness. And when those symptoms start and you're going along, and you get overt symptoms, you don't do well. Severe aortic stenosis with symptoms means there's a high risk that you could die. So why do we worry about dying? Well, we worry about it because we don't want to go down that path, and we have ways of fixing that. So how do we figure out what this murmur is all about? Initial assessment, history and physical. You describe to me what's going on. I'm short of breath when I go up and down the stairs, and we start working you up. Diagnostic imaging are the simple ones: echocardiography, CAT scan, a little more invasive. You have to do a little dialogue, but a standard CAT scan. EKG, everyone gets them in their family practitioner's office. And then, of course, more invasive procedures like cardiac catheterization through the wrist or the groin to look at the valves and the anatomy of your heart. And what we're looking for is stenosis, moderate aortic stenosis. That is, it's not that bad. It still has very bad mortality, just like severe stenosis. So when you have severe stenosis, 29% chance you'll be dead in 5 years just from aortic valve stenosis. And moderate stenosis, which most people just ignore and watch these days, 23% still go on to die at 5 years. So moderate and severe, i.e. a real murmur, carries significant mortality risks besides stroke and heart attacks and other things. And so we want to prevent that at all costs. Why do we want to prevent it? Because if we get it early, we can prevent this from happening. The heart works nicely starting off, then it gets thick to accommodate that narrowed valve, then it starts to die off, and then it dilates, and pretty soon, even though you have no symptoms, your heart starts to suffer permanent damage if you don't address the murmurs soon enough. So moderate and severe aortic stenosis, any amount of narrowing that's significant, whether you have symptoms or not, you could be just walking around. no symptoms. It's still bad. So we want to take care of it. When we find it, there's two options. You can fix it with surgery, or you can fix it by doing nothing. And you can see by doing nothing, you don't survive well. So you want to take any option you can to try and get it fixed. And we'll talk about those options in a little bit. The aortic valve replacement is for young and the old. Rondi Dangerfield, Robin Williams, Barbara Bush, of course, Barbara Walters, all had aortic valve problems, and they had to have them addressed surgically. There's a big misconception about age. If you're 90 years old, you think, oh, they're just inoperable. In fact, if you've lived to be 90, you're a survivor. You're going to live 5 more years. And that's why just yesterday I did 2 90-year-olds and replaced the aortic valves because it's worth it. So age is not as big an issue as it used to be, because we know if you get to be 90, you're pretty healthy. So age is relative. We can all look at these people and say, oh, young, old, whatever. But when you look at what defines old, debility, or what's frailty, one of these patients passes the eyeball test and one doesn't. And guess what? The one on the left and the right are the same age. So it's not just what they look like that matters. It's all the other tests that we do to decide if somebody is a good candidate to have something done about their murmurs. So first, find the murmur. See your doctor. That's the most important thing you could do. Use a stethoscope. You'll hear it. You'll hear that murmur that you heard earlier with a stethoscope. You can listen to it on yourself if you want, if you have a stethoscope at home, if you're taking your blood pressure or something. Here's what a normal aortic valve looks like on echo. You can see the leaflets opening widely, closing widely. Perfect valve. Here it is on 3-dimensional echo. Again, you see it opening nicely and closing nicely. Here's what the valve looks like. And it's starting to see some problems. You can see that the leaflets are a little thickened, and you notice how they're not closing. So here's a valve that's starting to degenerate, some aortic stenosis and some aortic regurgitation, which is why we were there to fix it in the first place. And aortic stenosis that's severe is a real problem. You can see how thick these leaflets are. They're just not opening, not enough blood's getting out. Same thing in the pictures, but you can see this is not a good sign. Here's what moderate aortic stenosis looks like. It's opening up part of the way and closing mostly, but it's certainly not good. And here's severe. It's barely opening up. You can't see hardly any opening in here where blood's getting through. And these are the people that are significant risk for sudden death, heart attacks, strokes, and other complications if we leave it untreated. So how do we find murmurs? Well, besides stethoscopes, get an echocardiogram. You just put the little sound probe like you do on pregnant women, but you move it over to the heart. You can look at the heart and hear and see what's going on with your valves. Here's a good heart squeezing nicely. I wish I had that kind of heart. But here's what happens when you don't treat aortic stenosis. This is the end stage congestive heart failure because nobody took care of the aortic stenosis. So now the muscle's dying and they're getting into more and more trouble, putting them at risk for all those complications. Here's what it looks like by angiography. This heart is barely moving. It's just squeezing a little bit. Not much blood is going forward and a lot's going backwards right to your lungs, causing congestive heart failure. Here's a bicuspid aortic valve. You normally have 3 leaflets for that valve. This one you can see only has 2. And look at all the calcium chunks. That's the way aortic stenosis is. It just builds up and builds up until the leaflets don't open. Here's a bicuspid valve in somebody who's young. It hasn't started to degenerate yet. And yet there's still some narrowing here. It's not wide open here. There's some narrowing, but we wouldn't fix this until later when it got bad. Here's an example of real surgery.
Just one solid rock.
Look at it, all just chunks.
You can force it open, but here's where stroke comes from. These little pieces of junk break off.
So you can see that the leaflets aren't moving. It's a bicuspid valve with chunks of calcium that are freely, sort of loosely hanging on there. And that puts you at risk for stroke. So among the risks of aortic stenosis, right, dying, heart attacks, strokes, that's where it comes from, are pieces of the calcium breaking off. So what do? We take it out. Here's 2 bicuspid valves, all white. They should be paper thin, looking beautiful. And these are all chunked up with calcium and scar tissue. And here's how we fix it. We replace it with a mechanical valve, which lasts forever, but you have to be on Coumadin. Or in this case, a tissue valve, a pericardial valve. We just suture it in after we take the old valve out. And then we take that artificial valve and put it inside the heart. The bubbling is just CO2 to decrease air around there, and it's got ice around the heart to keep it cold while the heart stopped. And then we tie it down. So now the patient's got a brand new aortic valve, in this case, a tissue valve. So open aortic valve or mitral valve or whatever valve we're talking about, you can see some mechanical valves here on the top right that last forever, and then some tissue valves. We have a lot of options. But the interesting thing is that aortic valve surgery is one of the most successful operations in history. It's one of the few operations of any operation you can think of. It stops you from dying, allows you to live longer, and eliminates symptoms. And almost no other operation ever invented for anything does that. So it's an amazing operation. There are minimally invasive ways of doing it. There's heart port, there's doing it by the robot, although that's only done at a few centers around the country. It's a bit tough to do. I don't want to call it not mainstream, but not every center does that because there are other ways of doing it that are even less invasive. Here's what a mechanical valve looks like. Again, you have to be on Coumadin for this, and a lot of people shy away, but it is one and done. You get one operation, you never have to worry about that aortic valve again. There's bioprosthetic valves, tissue valves, PIG valves, pericardial valves that work nicely. You don't have to be on Coumadin, but like me, we all get old. And these valves will last about 15 years on average. So something else is going to have to be done down the road if you're young and healthy and need it done. Here's what old school, it really does work. There's the valve before on the left, and with that new biologic valve on the right, it opens up nicely. So let's talk about TAVR. Transcatheter aortic valve replacement, also called TAVI, transcatheter aortic valve implantation, is a minimally invasive way of replacing valves without going on the heart-lung machine, without opening up your chest. Here on the bottom left, you can see Alain Cribier, who sadly just died a few months ago, did the very first one about 25 years ago in France. And it's a very successful procedure.
This procedure is
Grey's Anatomy knows.
And the great news is the scar will look like this. It's much smaller.
Yeah, but I want this instead.
What the hell is that?
That's my friend Tony's growing. I had him email me a picture last night. He had the same problem with his valve last year, and his doctor replaced it with a catheter through the groin. See, barely any scar. It's called a TAVI.
Yeah, a TAVI is an experimental procedure. There are tons of risk. Bleeding, stroke.
Look, I'm the one having this and paying for it, right? So if I say I want a TAVI, give me a TAVI.
Look, there is a much safer solution to your problem. It's called a rash guard. You wear it at the pool. No one will see your scar.
Clearly, you've never been to Palm Beach. Only fatties wear rash guards.
I can't get through to this guy.
He wants a TAVI. Look into it and decide if he's a good candidate.
I'll look into a TAVI.
See, now that's the answer I was looking for. I knew you had it in you, kid.
I talked to some other surgeons, but I'm not doing a TAVI on you.
And that's your final answer.
That's my final answer.
Well, things have come a long way since they promoted that new procedure many years ago. TAVR is now mainstream. Mick Jagger, in fact, they now call him Mick TAVR because he had one 4 or 5 years ago, and I saw him in concert recently, and he looked really good. So these devices work. And now transcatheter valve, doing it through the groin to replace the aortic valve, it exceeds the numbers of surgical aortic valves, actually for the last 5 years. So you have to ask yourself why. Well, there are two main devices out there, the Edwards Sapien valve, more than 500,000 patients worldwide have been treated with it, and the Medtronic Core valve, again, more than 500,000 patients. These first generation devices have worked. They've been around since about 2011. Here's what this is a Core valve. You can see the metal frame that self-expands. It's made of nitinol, nickel titanium alloy, and the PIG valve on the inside. And you can see it opening and closing there on the top. There's a surgical valve on the bottom, opens up all the way, closes all the way. It works very well. It's lasting anywhere from 15 to 30 years in the pulse duplicator in the lab. So far, we've got about 15-year data, 10 to 15-year data in the real world in Europe, and about 9 to 13-year, depending on the trial, here in the United States. And here's how we do it. We replace it. It's not going to go through. Hold on. Let me do it again. There we go. So we go in through little incisions in the groin, just needle sticks in the groin like a cardiac catheterization. And we simply unsheath it. It expands because of body temperature, holds in place, and then you've just crushed the old valve out of the way. And inside that area, you have a brand new pig valve, all done without going on the heart-lung machine and having to open the chest. It's a multidisciplinary heart team like the one we have in Crown Point. It's far better than just 2 heads and 4 hands. You've got a lot of people, clinical cardiologists, interventional cardiologists, surgeons, neurologists. It really does take a village to put these kinds of people through the procedures they need. Even though it's less invasive, it's far more intensive work by all of us to get people through these procedures, but there's huge benefits to doing so. The heart teams even beat AI recently. AI was only 65% accurate, so AI is still not out there, and I hope it never gets quite too much better than us anyway. Here's an actual procedure. This is done under fluoroscopy. You can see the aortic valve is all calcified there, and we're getting ready to deploy the device. First, we take a balloon and crack the leaflets out of the way to make room for the device, the new valve. So we balloon it up, and then we start deploying it. You can see us just taking the sheath. That's the sheath here, just being moved up. And once that sheath is moved up, the rest of the valve just deploys on its own. We hold it in place and just watch the magic happen. Then we release it at the top once we're satisfied with the position of the valve, all done while we're rapidly pacing the heart. And here's what you end up with, this beautiful valve. The coronary arteries look perfect on either side. There's no leak down here. The valve has been, your old valve has been pushed out of the way. It's over here in these little pockets. And inside this cage is the brand new pig valve. And here's what it looks like after we've deployed it. It's a perfect depth. It's moved everything out of the way. There's no aortic stenosis, so your risk of sudden death, heart attack, strokes, etc., down to 0. Here's the technology we use when we're in the hybrid suite. This is our system we have in Crown Point, but it can spin around and do all kinds of fancy robotic techniques to let us know what we're looking at. Here's an example of what we see real time while we're doing the procedure. We can even replace and fix surgical valves that were put in 10, 15 years ago. Again, the pig valves, pericardial valves eventually wear out. We can now, instead of reopening their chest to replace it, you can now replace it with a transcatheter valve alternative without opening up the chest. Sorry, that's not going to play. I'm going to get it to play yet. There you go. So you can see here, it doesn't leak. It's a perfect depth. The coronary arteries are filling nicely. Of course, I'm loving to teach, so that's me babbling away, but you can see that we can fix it and there's no leak. There's various valves out there. Those are the 2 main valves, the sapien valve and the core valve, but there are new valves coming out every day. This is direct flow done very differently. It actually is unfolded and then blown up. So it's like filling up your plastic toys when you're playing in the swimming pool. They can do the same thing on a miniature level. And new valves mean new opportunities. There's a lot of new valves out there. That's good for cardiologists and cardiac surgeons because I do it both ways. I'm excited to see all these new valves that are coming out that we can take care of aortic insufficiency, leaks, rather than just stenosis and whatnot. And we'll talk about that in a little bit. So early transcatheter valve replacements, really we could just do one thing, aortic stenosis for very straightforward cases. Now we've got multiple technologies and multiple techniques that help the current transcatheter valves that we have take on more challenging anatomy, shorter, taller, wider annulus, stiffer valves, leaking valves. So we've got a lot of opportunities when it comes to the aortic valve coming down the pike. So that was murmurs caused by stenosis narrowing. What about murmurs that are due to insufficiency or regurgitation, that is leaks? So let's pick on a different valve. The valve before the aortic valve is the mitral valve. Lots of reasons for the mitral valve to fail. Here's a normal mitral valve. The mitral valve, unlike the aortic valve, which is 3 leaflets, this one's 2 leaflets. That's normal, and you see it opening and closing nicely. But here you can see that it's not doing well. It's leaking backwards. All this is going into the upper chamber of the heart backwards, and that leads right to the lungs, which leads to shortness of breath. So you end up with congestive heart failure, not because of narrowing, but because of leaking backwards. Here's what moderate regurgitation sounds like. It's a different sound. I'll let you listen for a second. So it's different. Now you can hear it's going back and forth. So that's both stenosis and regurgitation. So it's not getting out and it's leaking backwards. And here's the reason why. You can see you can think of the mitral valve like a parachute with the cords that are holding on, and the cords are broken. You can see some of the broken cords over here that allow it to leak. And this is what happens when it leaks. It squirts backwards. So you end up with congestive heart failure. That's why we need to fix it so it doesn't go backwards. The gold standard currently is mitral valve repair during surgery. We can fix the outside, we can fix the inside, we can cut out some of the defective tissue. But what if you're too frail for a big mitral valve operation? You're too old, or you've had 3 heart operations in the past and nobody wants to take you. Now we have something called MitraClip. It actually clips the leaflets together so that here is a surgical leaflet that's sewn together called an Alfieri stitch. So now this doesn't leak anymore. The blood still gets through, but it can't leak backwards because the leaking area is put together with a stitch. Well, here we can do it with that same clip. You can see the surgical clip on the right and the MitraClip all done through the groin while they're awake under twilight. And so now it prevents mitral regurgitation, leaking backwards. We also have cardio bands, ways of making the annulus, the heart can dilate, and we now try to shrink it back down again to get those leaflets to match up in what we call coaptation. They form that one-way valve. And so we can do this now percutaneously in trials. It's not FDA approved. We do this in open surgery all the time, but it looks pretty interesting to me that we may be able to do this down the road through the groin. And then we actually have artificial cords. We're replacing the parachute cords, again, percutaneously. These are all in trials. But if you can get the clips, which are approved, plus the cords and the rings, all done percutaneously, eventually we hope to do a fully percutaneous mitral repair without opening your chest and going on the heart-lung machine. And we have endovalve mitral replacement. So let's say it can't be repaired and we just have to replace it like we do with the aortic valve. We now have a number of them in trial where we can put this device in, push the old valve out of the way, whether it's narrowed or leaking, and you have a brand new valve on the inside. There are numerous percutaneous valves currently in trial. I think there's at least 12 that I'm aware of. There's probably a few more that are going to be online in the next couple of years. So lots of opportunities in that area also. The third valve, and we'll just pick on the tricuspid valve. We've done the aortic valve. We've done the mitral valve. What about a leaking tricuspid valve? It's the first valve. We have clips for that one also. That just got FDA approved recently so that we can prevent the blood from leaking backwards as soon as it gets into the heart. So it'll decrease symptoms of lower extremity swelling, for example, and swelling of your liver by preventing that valve from leaking. It rarely gets narrowed. So there's only one device right now for it leaking, and we now are going to start using that here in the United States. There's a fourth valve called the pulmonic valve. I don't want to call it the least important, but you can see here that this fourth valve, which goes towards the lung, this is a 5th time redo in a young woman about 17 years of age, still growing up. She's had 4 open heart operations to fix various valves as she grows, because the valves we put in don't grow with her. She gets too big, then we have to put in new valves. So now we've got a technology that percutaneously fixes the pulmonic valve to allow her to grow until she's fully grown at 21, 22, 23 years of age. Then she'll either get a final replacement of whatever valves are there, or she'll be a heart transplant candidate. But we got her through that without having to operate on her because we can do it percutaneously. There are other kinds of murmurs, and let's talk about murmurs that aren't related to valves, but are related to holes. There's the holes in the upper chamber, the atria of the heart. And we can go under echo and fluoroscopy and deploy these devices. It's like 2 umbrellas on each side. Plug one side of the hole. There's the umbrella, plugs the other side of the hole. And if they're amenable to this, this can be done again under twilight while the patient's awake. I can certainly fix this in surgery, but it requires real open heart surgery. We can do a lot of these now through the groin. There are holes in the bottom chambers of the heart, the ventricle. Those are a little more devastating to have, and so we try to fix them at all costs. Again, can be done with surgery, much bigger operation than the upper chambers. But again, the same kind of device made for higher pressures. You open up on one side, there's your umbrella on one side, you plug the hole and put the umbrella on the other. That eliminates the need for open heart surgery. So in the end, it's all about choices. We've got to find the murmurs. So I strongly encourage you to listen to your own heart. If you have a stethoscope, get in to see your doctor to have it looked at. If you need an echocardiogram or other advanced tests, they'll certainly send you to a cardiologist or somebody like myself to put you through that workup. I think of that old car on the left as the one I would want, but old school isn't necessarily best. It works. But I think if we look at old school and new school, that is standard valve surgeries when necessary, transcatheter valve, minimally invasive surgeries when appropriate. It doesn't really matter how you fix the murmur, although some murmurs we watch, but most murmurs we fix. We want to be able to go to a site that can do both of those things. So you want to choose wisely. Get that evaluated, that murmur evaluated at Franciscan Hospital at Crown Point, or any hospital, any doctor's office. You want to have that technology, the open surgery and the transcatheter valve options available to you. We have it here. A lot of centers don't. So you want to go to a center that does a lot of these. Here, I just am going to end with any questions, but this is our very first TAVR patient that I did. She's actually a walking billboard. Asked me about the TAVR procedure. On the back, she says the date of her procedure and call Dr. Tuchek. So she's a great lady. And I'm going to stop there, see if anybody has any questions, and let Jennifer get back on, and we'll go from there. Do I need to stop sharing my screen, Jen?
No, you're fine.
Okay.
Yes,
Okay.
thank you. Yeah, thank you, Dr. Tuchek, for a great presentation. Covered a lot of ground in that. And anybody who has a specific question, please put it into the Q&A box at the bottom. Yeah, if you have any specific questions, as I'll start out with one, Dr. Tuchek. How important is it to know your family history of heart disease and maybe about heart valve disease in particular?
So that's a great question. So as you know, a lot of heart disease, whether it's blockages causing heart attacks or valvular disease, are passed along genetically. And so if you know your mom had a bicuspid valve, 2-leaflet valve, even though you should have 3, you kind of need to know that ahead of time. Let your doctor know, hey, mom and dad both had this. Therefore, they'll watch a little more closely, get that echocardiogram at a slightly younger age, maybe at 30 or 40 or 50, rather than waiting until you get symptoms, just because they know you're in a higher risk category. So knowing that ahead of time is helpful. Knowing your own history, make sure you let your doctors know that, hey, by the way, I was told as a kid I had a murmur. A lot of kids have murmurs. They usually go away, holes close, etc. But if they consistently, every time you see the doctor, they're saying, you've got a murmur, you've got a murmur, you've got a murmur, I wouldn't ignore it. A lot of them do, but I wouldn't ignore it. I would just make sure, based on more invasive tests, whether it's an echocardiogram, which is nothing, just a sound test on your chest, just to make sure it's not the kind of murmur that we'd like to address or follow more closely, get an echo every year as opposed to once in your lifetime. So knowing that history is very helpful, Jeff.
All
Any
right.
other questions?
Yes, I'm writing these down. There are a couple of people who are very specific about their questions. So they, like I said, they have been told or they've discussed the heart murmur situation with their doc, it sounds like. One question is, how dangerous is a heart right bundle branch block?
Block, yeah, right bundle branch block. So the conduction system in the heart starts in the top chambers and goes down to the bottom chambers. And there's various pathways. One goes to the right side of the heart, one goes to the left side of the heart. So if the right side of the heart, the nervous tissue going down there gets blocked for whatever reason, a heart attack, something, then the conduction's abnormal. And if the left side also goes down, you end up needing a pacemaker. Or, worse yet, you go into complete heart block, in which case you pass out. Or, of course, the most catastrophic is you could die from that. But that's not what usually happens. Usually you get a complete block. Your heart rate now is 30 and you feel awful. You want to pass out. You're tired. Something's not right. You're short of breath because your heart rate, instead of beating at 80 beats a minute, is doing 30. So you'll need to take an ambulance, get in, and they'll put in a pacemaker. You want to look for the reasons for that bundle branch block that you've got. So look for things like heart attacks, valvular disease, some reason. But a lot of people just are walking down the street and all of a sudden they go into heart block and need to have it addressed. So follow up with your cardiologist or your electrophysiologist, the pacemaker specialist, to make sure you don't need something like that to resynchronize your heart, get it back into a good rhythm. You've heard of atrial fibrillation, the irregular rhythm, everyone talking about the Watchman procedure. Again, another minimally invasive device. Those are procedures that are important for ablations, trying to get you back into a normal rhythm. They cardiovert, shock you. You see them, paramedics shocking people on the street. They do that while you're asleep to jumpstart your heart back into normal rhythm. So all those rhythm issues are important because they affect your valves and how well they function. The squeezing function of your heart doesn't squeeze well when the conduction system's not working well. And so you want to address those ahead of time with seeing your doctor about that.
All right. One question about are valve replacements applicable in left ventricle hypertrophy?
Yeah, so you can't see me very well, but you can see in the picture that I think that's still on the screen. I'm kind of a skinny bloke, but if I exercised and took steroids every day for the next 15 years, I might look something like Arnold Schwarzenegger. And the reason is because I'm working my muscles overtime. So think of it in the heart now. When you've got aortic stenosis, you're pushing against a narrowed outlet. I have to work harder. That means my heart works harder. As my heart works harder 24 hours a day, 7 days a week, 365 days a year, for years, it gets thick like Arnold Schwarzenegger's arms. Now, if you fix it, of course, if Arnold Schwarzenegger stopped exercising, he wouldn't shrink down to my size, but he would shrink down more. And that's important because if you fix the cause of the left ventricular hypertrophy, the thickened muscle, you want this to be a marathon, not a sprint. I can't outlift Arnold Schwarzenegger, but I can outrun him. And a heart needs to be efficient and run for a long time. So if you've got left ventricular hypertrophy, for whatever reason, if it's related to valves, if it's related to high blood pressure, you want to treat that because there's long-term health side effects that you don't want to go through. And so that's important to fix. We frequently see that almost always when you have aortic stenosis, aortic regurgitation, simply because the heart muscle is working overtime. So definitely need to have that evaluated to see if it can be treated, even if it's simple, like fixing your blood pressure with the right kinds of medicine so your heart doesn't have to work so hard.
Okay. One question about moderate to severe mitral valve prolapse and regurgitation with no symptoms, but the person says he's seeing a cardiologist. What should trigger valve repair solution for me? Yeah.
Sure. So the mitral valve prolapse is not very important. A lot of people have it. And that just means the leaflets are just a little bit not perfect, leaking just a little bit. Maybe not even leaking at all. They just bulge a little too far in the other direction. But if you've got mitral valve prolapse, that's a signal to your doctor and to you that, okay, let's just watch this a little more closely. When you start getting more severe prolapse, that is real regurgitation, real insufficiency, real leak, not just a little bulging backwards, but now going backwards a lot. Now you're overworking your heart for a different reason. Blood's going backwards into your upper chambers. That leads to that irregular heart rhythm, the atrial fibrillation. And then it goes back to your lungs, congestive heart failure, shortness of breath. You feel winded, tired. You can't mow the lawn, etc. So when you start having significant regurgitation, and that's on echocardiogram, then you have to decide if it's a lot, it probably needs to be addressed with surgery, clips, the things we sort of talked about earlier, whether it's mitral valve repair or mitral valve replacement, mechanical valve, tissue valve, the clip you saw earlier. But if it's only mild to moderate and you're not having symptoms, we usually recommend watching it because there's risk of all those procedures. And the risks of mild to moderate mitral regurgitation are not that significant. Once they start giving you symptoms, once that heart starts thickening and becomes less efficient, then it is an indication for you and your doctor to consider mitral valve repair, mitral valve replacement, the mitral clip, something to decrease the amount of leak.
All right. One person comments that she has a diagnosis of moderate valve stenosis, although it sounds like now she's having some symptoms of fatigue and dizziness. And she's hoping to get into the physician's office here.
Sure. Come to see me anytime. 219-662-0077. We're happy to see you. And I say that because we're happy to see you because there are a lot of people, I'll call it old school, and I guess I'm old school, but I'm also new school. Old school, 20 years ago, you'd have to be pretty darn sick for them to send you to a surgeon to put you through open heart surgery. But now we know that even with no symptoms, as you saw in one of my slides, no symptoms, if you're a relatively healthy person, no symptoms, moderate or severe aortic stenosis, moderate or severe other valve problems, there's a survival benefit to having it fixed, replaced, repaired, whatever it is, as opposed to doing nothing. So we're much more aggressive about repairing and replacing valves, whether you have symptoms or not, because we know that there's a survival benefit, as long as you're not 95 on dialysis, on oxygen, and wouldn't tolerate any of those procedures, then there's no survival advantage. We wait until it becomes severe or symptomatic and then address it because that's a much riskier procedure. But if you're a 65-year-old person and you've got a little fatigue, okay, you and I are getting older. But if it's fatigue and a little bit of I'm getting dizzy and a little bit of I'm getting winded during sex and mowing the lawn and shoveling snow and exercising and carrying laundry up and down the stairs, whatever it is that works up a sweat, and you're starting to feel it, if it's not just, you and I are deconditioned, I'm not going to the gym, it might be the heart's not working well. You don't know that. Go in to see your doctor, get that echocardiogram, have them look at it. Maybe it's related to valves, maybe it's related to high blood pressure and it's getting thick. Look for a reason. And if they find nothing, great. You've ruled out the bad things. Then you can look at, it's my thyroid, I'm just not going to the gym enough, the benign reasons for being fatigued. But look for a reason. Never assume I'm just depressed, I'm getting old. Never assume that. We're all getting depressed, we're all getting old. But look for reasons for it first, because we have a lot of new technologies, old and new, that work. And if they can reverse that process and make you feel like $1 million again, the 55 is the new 35 sort of scenario. With these technologies, we can do that for many people if you qualify and if you've really got the disease. So definitely see your doctor about it.
All right, we have a few more questions. Let me see. Oh, with TAVR, is that done through Twilight? Is that Twilight Conscious or
general anesthesia?
Yeah, general anesthesia.
Yeah. So the transcatheter valves, there's different kinds, but I'll just talk about aortic valves, for example, the mainstay that we talked about for the most of the talk. When we do that, it can be done under general anesthesia. Some people need general anesthesia. Some people prefer, I don't want to hear what my doctors are talking about, right? They've not liked that experience. Other people tolerate, MAC, that is super duper twilight, where you won't remember it, you'll be asleep through it, but you won't be on the ventilator like general anesthesia. And there are some advantages to that, less nausea and whatnot, because you're not getting general anesthesia. And so there's two ways of doing it. Your doctors will evaluate whether or not you're a candidate for one or the other. I do that every day. I decide this one I think I can do while they're awake. This one, definitely go to sleep. Some people say, I'm going to sleep because that's the way it's going to be. They don't want to hear it. They don't want to feel it. They don't want to, but you don't feel it and you don't hear it. But they have that preoperative feeling that I don't want this done any other way. And that's fine. We can do it either way. So there's lots of options for transcatheter valve. Open surgery, of course, requires general anesthesia every time.
One question, if there are like pre-existing conditions, I guess, with a murmur, if you have an abdominal aortic aneurysm and a heart murmur, would the murmur be treated differently? Or
No.
maybe no.
No, it wouldn't. I do, as you saw from my bio, I do a lot of trials for endovascular stent grafting for aneurysms. Aneurysms around the heart, aneurysms in the chest, aneurysms in the abdomen, especially. That's the most common. It's what Einstein died from, an abdominal aortic aneurysm. So the aneurysm is treated separately. We can go through an aneurysm to fix a heart valve if we need to with a transcatheter valve. But definitely both need to be evaluated by a specialist to determine how big is the aneurysm, for example. And if that's really big and your aortic valve's not that bad, fix the aneurysm. Don't worry about the aortic valve until it gets severe. So I happen to do both. So I would see the same patient for the same things, but go to see those specialists that do both, and they can determine, is the aneurysm big enough to justify being treated? And is the valve at the same time, is the valve bad enough to be treated? And then decide which takes precedence based on all kinds of medical issues, anatomy, other medical problems the patient has. And then we can determine, leave the aneurysm alone. It's only 4 centimeters. Fix that aortic valve because it's critically stenosed.
Okay, another question about if radiation treatments could cause some kind of heart valve stenosis.
Yes, so we see a lot of people who've had Hodgkin's lymphoma and they get mantle
That's
radiation.
exactly, yeah.
Yeah. And a lot of people in the original trials, when I started the original trials here in the United States back in 2011 at Loyola, a lot of people, I'll operate on almost anybody. Now that we have a transcatheter valve option, though, a lot of people ended up going for transcatheter valve options in the trial, even though it was experimental at the time, precisely because they ended up getting radiation damage to their chest because they had lung cancer, non-Hodgkin's lymphoma, something like that. So going in and doing open chest surgery for somebody who's been irradiated, where all the scar tissue forms, is really difficult to do. When you add to the fact that that radiation itself can cause, like chemotherapy, cause the muscle of the heart not to work well and actually cause damage to the valves and the coronary arteries, higher risk of heart attacks from blockages, higher risk of aortic stenosis. Usually it's stenosis, not regurgitation. With radiation, it causes scar tissue like the calcium buildup, and you end up needing a valve done at a much younger age. Mantle radiation at 30 for Hodgkin's lymphoma. At 40, we're replacing their aortic valve because it's degenerated prematurely thanks to the radiation. But that's another advantage of doing it through a minimally invasive approach, TAVR, because we can get away with not opening the chest and replace it just as effectively.
All right, well, those are all of our questions. I did have one question about, you're talking about the holes in the chambers that can cause some issues, that they're not valve related. Would those be due to some birth defects, or how do those come to be?
Sure. So in the bottom chambers of the heart, a ventricular septal defect, heart attacks cause that, and you'd know it because that's a real life-threatening problem. And your doctors would find it after a massive heart attack, for example. And that's not what, that's what I see a lot, but that's not what most people are talking about. Most people are talking about holes in the heart that you happen to have, you were born with them. And that's fairly common. Upper chamber holes, atrial septal defects, we all have them. 100% of us have a hole in the heart in the upper chamber that was there, and it was open because we weren't breathing in the womb. Then we take our first breath, the pressures change because now our lungs have pressure going to them, blood going to them because we're breathing once we're born. And that hole in the top, the flap closes, called the foramen ovale, and never have to worry about it again. But in a number of patients, as we get older, pressures in the heart change, And sometimes, for a lot of different reasons, that flap opens up again, and now there's that open hole that's allowing blood go back and forth between the upper chambers. And most holes, if they're significant, that is big enough, warrant evaluation and treatment. Sometimes it's just blood thinners to prevent clots from going across. Sometimes it's those the two umbrellas that kind of go together like we saw earlier. Sometimes it's open surgery depending on the kind of hole it is. But they should be addressed, especially if you've got one as you get older. Kids have them all the time, and they usually watch them because they grow out of it. That is, the hole closes as the child develops. Some still need surgery for big holes, but most of them we can watch. So again, definitely something you need to see your doctor about so they can follow, usually by echocardiogram.
All right, well, we're coming to the close of our time. I'll take one more question, and not related to valves, but someone asks, what are your thoughts on the CT cardiac coronary scan? It gives you scores. It's a calcium. I think she's talking about the calcium
Scores. Yeah.
scores.
So with aneurysms, with heart disease, and with lung disease, if you're a smoker, I'm a big proponent of going out there and getting the heart screen. It's $59 for all three at Crown Point. It's a various cost at different places, but I strongly encourage it if you're a candidate for it, because it does give you some, not all, but some information about, hey, I was a big smoker and I've got some lung nodules. Now I need to follow up more closely with real follow-up, pulmonologist, better CAT scans, et cetera. Aneurysms, just do the ultrasound over the abdomen. If you don't have one, don't worry about it. If you do have one, see your doctor. You can start following it more closely, because both of those are completely asymptomatic. You don't know you have them unless you look for them. Just like why we get guaiac your stool and get colonoscopies. You don't know you have colon cancer until you look. Mammograms, same thing. Pap smears, same thing. With coronary calcium, about 70% of the blockages that you have calcium. About 30% don't. So it doesn't pick up every blockage. But there's a good chance that if you've got lots of calcium, some of those calcified lesions in your heart arteries could lead to narrowing and therefore a future heart attack. So anybody who's at any risk, and me, it's eating potato chips for breakfast sort of risk, or they smoke, which causes blockages, or they drink too much, or they have a strong family history, they have a high cholesterol, they're diabetic, they have high blood pressure. The risk factors for blockages, the heart scan can pick that up, the calcium, more often than not, and make your doctor aware that, hey, this is somebody we need to watch more closely. They need more invasive procedures, a stress test. It's just a chemical stress test. They do treadmills, but you can do a chemical stress test. Or if it really looks significant, an angiogram. Let's look to see how bad are these blockages. Do you need a stent? Do you need open heart surgery? Do you just need medicine and cholesterol medicine and aspirin? So I strongly recommend that if people are in any risk, family history, et cetera, like I just mentioned, get the heart scan. It's quick, it's simple. It takes 5 minutes. And that way you have an idea about what's going on the inside that otherwise you can't see until it's a little too late and you start getting symptoms or have a heart attack or something else catastrophic happens.
Well, thank you so much, Dr. Tuchek, for this presentation and for taking the time to answer everyone's questions. Okay, so for our participants who are attending, we'll send you an email with a link to this session, and we encourage you to share this presentation with other family members and friends who might be interested. We will also ask you to fill out a brief survey about the program, and your input will be very helpful in helping us plan future webinars, which I will be doing here, I'm sure, shortly for 2025. If we didn't get, I think we got to everyone's questions, so that is great. Our next webinar in this series is December the 3rd, and that will be on atrial fibrillation, and we hope you can join us for that one. To listen to more presentations by members of our Franciscan Health medical staff, visit our podcast page at franciscanhealth.org/podcasts. And on behalf of everyone at Franciscan Health, thank you for being with us tonight. And thank you again, Dr. Tuchek, for taking the time to put together, to give us such a great presentation.
It was my pleasure. Thanks so much, Jennifer.
Sure. All right. And we'll wish everyone a great rest of your evening. Thank you so much.
Thank you.
Mm.